Good morning. Glad to have Chairman Zuber with us today and members of the Senate, and Representative Ford is new, I believe. We had a wonderful presentation from the Commissioner of Insurance in Louisiana yesterday on what they've done with pre-authorization, gold card legislation. We know there's a bill that's been passed in Texas, and those two versions are quite different. And so we're going to study the issue a little bit more. The bill came up last year, kind of late in the session, and we had very quick hearings on it, but we want to give it its due and discuss it and let the committee members ask any questions you have on the issue, because it's certainly an issue. I wasn't aware West Virginia had passed it, but Commissioner Donlin had mentioned that. So, and NCOIL, the National Conference of Insurance Legislators, obviously have made a point that it's something they want to study because they've had presentations, and so all 50 states are aware of it. So it might be before us. It will be before us, but it might be very popular in other states as well. So what I'd like to do is turn it over to Sydney Allen, who's going to introduce. We have two great speakers this morning, and well, three great speakers, but two on this particular issue. So Sydney, thank you for being here. Check that mic, please. Make sure it's green, it's turned on, and we
green light
being here this morning.
Thank you, Chairman Michelle and Chairman Zuber, and members of the committee for having us here this morning. Last fall, we came before you and introduced a new physician group called the Mississippi Independent Physician Practice Association that was being formed to represent independent physicians in the state of Mississippi. Those are small businesses, essentially, where the physicians own their practices. This morning, I'm here to introduce one of our key members and the chairman of our Government Affairs Committee, Dr. Stephen Chevalier. Before I do, I will say the Louisiana commissioner yesterday, I thought, gave a nice overview, sort of a he said, she said of the issue, gave the pro, one side's argument and the other side's argument. So it's sort of a neutral grounding of the issue. I think today you're going to hear from the physicians and the doctors who actually take care of the patients and are taking care of the Mississippians, to just so you know just how tough the prior authorization abuses are right now in the state. Dr. Chevalier grew up in Mississippi and attended Ole Miss before he went to med school at UMMC. He then went off and completed his pediatric training at the University of South Carolina in Greenville, and he went on to become chief resident there. So quite literally, he could have stayed there or gone somewhere else, but he decided to move back to Mississippi and begin his career here. And he's been with Children's Medical Group, which is located in Madison, for nearly 25 years now. So he takes care of tons of patients, as you might imagine, especially children in our area. And we're just very fortunate that he was able to carve out some time this morning to be here with us in person, come talk about some of the challenges they're facing. And I don't want to take any more of his time, so I'd like to introduce Stephen Chevalier.
Dr. Chevalier, I'll thank you for coming back as well from South Carolina to practice in Mississippi. We sure appreciate your commitment to the state.
Thank you, Chairman Michelle and Chairman Zoomer, for being here, members of the committee. I appreciate the time y'all given us to come speak to you. As Sydney so graciously said, I did grow up in Prentiss, Mississippi. I went to Ole Miss, had a wonderful 4 years there and a great weekend last weekend there. Hotty toddy. Okay. I went to medical school here. After finishing, went to my pediatric residency at the University of South Carolina, stayed there as a chief, and then stayed there on the teaching faculty for a couple of years. When my wife and I decided to have a family, we decided we wanted to come back home and that we wanted to rear our children here, and we wanted to do our part to try to make healthcare in Mississippi better tthan it was at the time and try to improve the healthcare for our children. When we were talking about this, what I was going to say, I want to make this very real world. I want to let you know what we go through as small business owners in this state, dealing with prior authorizations and what it means to our patients, because first and foremost, it's our patients that matter here. It's not us. I mean, yes, we want to be able to keep the door open, and yes, we want to be able to, pay school tuition and those things, but we want our patients taken care of in a timely manner. As I look in this room, it kind of was the setup I wanted. There are lots of people in here I know. There are people I went to undergrad with. There are people, at least 8 people in here that I take care of their children. There's 2 others I take care of their grandchildren. I have a cousin sitting in the room. I have, and so Dr. Hayes, who's speaking next, is my college roommate's first cousin. So it's a very typical Mississippi room, and that's what we're talking about. You know, this is family, and we want people taken care of, and so that's why we're here to talk to you today. As he said, I've been in practice with Children's Medical Group here for 23 years. I was talking to somebody just a minute ago, to Claude Brunson, and I said, I can't believe I woke up the other day and was one of the old guys, because, you know, I still kind of feel like one of the new guys, even though I'm the second most senior in our group. Those of you whose kids, probably a lot of your kids went to our group, I jokingly call us the big old group. We were founded in the 40s, have been continuously practiced here since then. We now have 3 locations in the greater metro area: Clinton, Jackson, and Madison. I'm primarily in our Madison office, but we are open 7 days a week, and our after hours, so our night clinic and our Saturday and Sunday clinic, are in Jackson. We'll get to spend all day Saturday there this weekend, so I'm glad the Rebs are on the road. So that's sort of our practice setup. We all know how tough the last couple of years have been with COVID. So, you know, physicians' emphasis should be, and I hope almost all of ours are, our patients. And so we've really not paid attention, I feel like, well enough in the last handful of years to the changes in legislation and the changes in the way the insurance companies have started dealing with physicians. And so I think we all kind of had a collective sigh and woke up and said, look, we need to do something. You know, the state medical does a wonderful job. Everybody in MIPA are members of the state medical too. So we're not trying to go against the state medical. We're trying to find representation for the independent physicians, because we feel like the representation is pretty good for the big, you know, hospitals and those things, but that we needed a voice to represent those of us who are one doc by themselves, two. I mean, we're a bigger group in the sense of this, but there's still 11 partners. So we're not, you know, we're not a big corporation. And the burden of the cost of prior authorization on our patients, I'm going to reiterate multiple times, but on our practice has been quite large too. I look back to make sure my stats were correct on this, but 5 years ago, we employed 1 part-time insurance clerk to help us with prior authorizations. And she was able to get the job done in 20 hours a week. We now have 3 full-time ones. They're not able to get it done. They're weeks behind. We have had to go back to our nurses having to do them again too, which takes away from patient care. And unfortunately, we've really had to go back to where a lot of times the physicians are spending more time than just filling out paperwork for this. A lot of places have employed these middlemen, I'll call them, where I have to call, I'm on hold for 15, 20 minutes to get through. I will admit, I've never had one time when I've done this, and I've done it dozens of times now, this has been a new thing in 2022, that they've denied my claim, that as soon as they talked to me, they approved the CT or the MRI, whatever I needed, but every one of them have taken 20 to 30 minutes, which for those of you who have kids, you know, kids aren't like when you get our age and you're sick, where you come in with a bag full of medicine and you got 10 problems and it takes an hour to work through it. You know, kids come in, they've got an ear that's hurting. And so, you know, I can look them over, diagnose their ear, give them what they need, and take care of them in 10 minutes. So that's 3 patient times for every time I have to get on the phone and deal with that. That's people I can't get taken care of that day. You know, the problem we're talking about with prioritization are the delays that are happening in getting these things improved, the denials, the abandonment of care. You know, we'll talk a little bit about how there's a high percentage of patients who just basically give up. They lose the war of attrition. It's like if you've ever lost your bag with the airline and you try to get your money back for it, you know, after 400 phone calls and letters and you got your attorney buddy to write you one, you just give up. And it's kind of the same thing there. I want to talk a little bit about how this affects different physicians differently. At MIPA, like he mentioned, we formed almost a year ago this week. Dr. Jay Underwood came and spoke to y'all last year just to announce our presence. And that was one day after our first meeting. So obviously we didn't have really anything going. So we did surveys, state medical's done surveys, the AMA's done surveys, asking what's our number one problem. And ours, over 85% of our respondents in MIPA, prior authorization was by far their number one problem and the main thing we wanted to address and bring to you guys today. As the commissioner from Louisiana brought up yesterday, I was able to watch that last night at home. The AMA's number with that is that 94% of patients who needed prior authorization for anything were delayed in their care. And that's pretty significant. Also, that the average in the US is that per position, per group, that 40 PAs are done a week at an average rate of 16 hours for these. So you're talking 2 full days just to get these things through. Depending on our specialties within our group, it changes where your headache is. With what I do, I don't order a ton of CTs or MRIs or high expensive procedures. I might literally order an imaging like that once a month. But medicines I'm doing every day, and medicines I'll have 8 to 10 prior authorizations a day. And the problem with this, it's not medicines that were, a lot of times our issue is it's a medicine that a patient has been on for years. And it's a medicine that we had a very difficult time finding the right medicine for them. And that it was paid for 3 years. And then all of a sudden with no notification or anything, it's not paid for anymore. And so we jump through these hoops trying to get these kids. I have to write letters proving that they failed other medications. I have to write letters proving that they had these side effects on other medications. I had one particular patient come in mind because I've dealt with them again in the last week. The beauty of a computer system, us as physicians, we don't love EMR completely, but there are great things about it, is that you can farm any data you want. And so I pulled this patient up and I looked since March 1 this year, since their medicine got denied, I and my office and my insurance clerk and my nurse have dealt with the insurance company 38 times on this single patient for a medicine that's $130 a month. I'm not saying that's nothing, but we're not talking about an experimental medicine that's $3,000 a month, that kind of thing. And we're still denied with this patient at this point. So this is what people are going through in this. In our colleagues that are surgeons and procedural based, like Dr. Underwood, GI, it's the procedures that are getting denied. And these are delaying surgeries and they're delaying life-saving procedures in these things. We feel there's got to be a better way to get these things addressed and get these things rectified and passed so that in a timely manner, our patients, your constituents, can be taken care of. Other things we see the insurance companies doing, and when I say this, I'm not, we don't deal with problems with all of them, but are waiting till the last day of the approval process to deny it. And then what happens is, well, you've had that 15-day window, the patient's waited to that, it's denied. You have to formally file an appeal, which starts a whole nother time clock. So that procedure was probably scheduled at the end of your period. And so then it has to be canceled hours before those things, which takes that time from another patient or those things. We also see, that these codes are added and removed without any notification. We'll have, the way that we have to file this and everything, and then the next day it's not there anymore, which causes a major headache. And then not something I deal with in my world, but when it comes out that you're coming to speak at this, and we have a membership of roughly 300 physicians in NIPA right now, we're still growing daily. We represent the entire state and almost every specialty. I've been getting phone calls from people for the last week say, look, this is what we're dealing with. From our surgical counterparts, they're dealing with where there's only 24 hours for them to amend their code. So let's say a general surgeon's going in on an explorative surgery on you. Well, they don't know exactly what they're going to find. So what the actual surgery is defined during the process. And so they only have 24 hours after that to fix those codes, to get them in. Then they have to wait the long time before the approval comes of those things. And the procedure's already been done. And sometimes if they're not approved, well, obviously they don't get paid for something that was necessary. As was mentioned, we did have 2 bills come up last year. It was Senate Bill 2449 and House Bill 780, which were both in the committees. We started in October. So like Chairman Michelle said, these were late to the table, but we wanted to get something in so we could start this dialogue. Both of those bills were based on the Texas bill, which the Louisiana commissioner did mention yesterday. One thing I'd like to point out about the Texas bill, though, that's going to address one of the criticisms we've had about this was how it came to be. It was a joint bill from the insurers and the providers. It was not a provider bill that just came out and then got approved. So the providers wanted an 80% approval. It was a compromise and brought forth by them jointly at a 90% approval is where that number came from. The Texas bill, as we all know, just went into effect on October 1. So we'll start getting data from that, before we know it. The West Virginia bill, as I mentioned, came out in 2019, and we'll have collective information there. And as he mentioned yesterday, 8 to 10 states right now have bills that are going to be looked at and probably something done, very different at different places at that time. So we liked the structure of the Texas bill. We felt like 90% was very reasonable. I know they were passing around 95, 97. And in my opinion, the argument that if 90% is the threshold, that 10% of everything is going to be unnecessary is ridiculous. I think the physicians who are conscientious enough and trained well enough to achieve the 90 aren't going to be trying to push off 10% of them fraudulently. We don't have the time to sit there and do the math to figure that out. So I don't think 90 is an unreasonable number. I think the criticism that we were last year was that we were going to be one of the first states doing it. Is kind of quickly becoming a non-criticism, because as we know, it looks like we'll be, if we did something this next year, we'd probably be in the first 10 or so doing something, not the first one. Also, the other big argument was, would the insurance companies have time to respond to this? And obviously we feel like there would be ample time. In the bill, if we were able to bring a bill forward in January, we would ask for a January 1, 2024 time period for the beginning of the 6-month approval period, which would mean the first approvals wouldn't come out to July 1 of 2024. And obviously we know the insurers track every prior authorization that goes through there. That's already in their systems. It's already there. It's already per doctor. It's just tweaking the numbers so then we'll be able to look at it to be able to then apply that to the gold card so that we can see, reward the physicians that are doing things the right way and allow these patients to be able to be taken care of in a quicker, more efficient manner. I was talking to my friend Mark Garriga, and he brought up the analogy, and I thought it was a good one, that what we're asking for is kind of like a TSA pre-check, where you're vetting, you're clearing this, but your checks and balances are still in place. So we're trying to make something more efficient and work better, and I think that's a good way to look at it. So I think that hits the major criticisms. I did want to say, bottom line, what we're asking all of our patients and constituents to do is to wait. We're asking for them to wait for the proper health care they're supposed to get. We are all people in this room that have dedicated ourselves to Mississippi. That's why we're here. That's why you guys are serving. That's why we serve in our own way. And so we want to make the state better. And I would like to see our healthcare statistics improve. I had never done anything down here at all. I kind of said, look, I'm a doctor, I have an office manager, so I don't have to manage the office. There are people at state medical to do this. And like I said, we felt like we had to get involved. But I realized about 5 years ago, and I don't want to discuss this issue, but I realized about 5 years ago with the vaccination exemption laws that were being proposed, that it was time for me to get involved. So there are some of you in this room that I have talked to on the phone over the years. I wore my buddy John Horn out, talking to him every year about it. John Polk, who is apprentice guy like me, my buddy Briggs Hobson, that we were at Ole Miss together, to try to keep Mississippi #1, and one of our only #1 health statistics that's pro is we have the best preschool vaccination rates in the United States. And it's also why we have the lowest rate of the vaccine preventable illnesses in the United States too. So that's why we're involved. We want to make a difference. We don't want our patients to have to wait anymore. One of those other phone calls I got was from the Hattiesburg Clinic just the other day. They said that they were averaging on their pre-approvals, prior authorization approvals now up to 15 days, which is for a lot of these things is just way too long to wait. And a lot of our patients don't have time to wait. You're in this time where we're at the lengthening hospital stays. We have cancer cells that are growing. We have diminished health. Like I said, we have people that are just giving up and not getting their health care, which we don't want that. So I feel like Mississippi, along with the rest of the country with this issue, we're at a pivotal moment. We're at a time where we can join together and we can kind of figure out how to address this issue. As physicians, we don't have the perfect answers. That's why we're going through this process. But we do think we have good ideas, and we do think we have a way to work with this. We really look forward to working with you guys some more. I got to meet 4 or 5 of the members of the committee last year and spent some time with them, and I felt it was very productive, and we look forward to that too. So I'd just like to say, it's physicians, hospitals, nurses, healthcare providers. We feel like we're really a real disadvantage in dealing with the insurance companies. We're not big enough, small mom and pop operations, to have the machinery to do this. We can't have full-time attorneys and full-time lobbyists, and we can't even have part-time ones really for those kind of things. And so we need you guys to help. We need you to help the constituents of the state of Mississippi, all these patients that we're trying to help. I appreciate everybody listening to what I had to say. I hope it was helpful in some way. I am no expert in the law or legislation, but I'd be happy to answer any questions that I could.
Dr. Boyd.
Dr. Chevalier, yesterday, the Louisiana commissioner testified that Louisiana is not they're not really looking at pharmaceuticals in this prior authorization. I'm one of the senators that you got to meet with last year, and you kind of went through it more in-depthly with me, particularly in regards to your practice, in regards to looking at behavioral health. Can you expound on that and whether or not you think we should be looking at pharmaceuticals as well?
Yeah, from my standpoint, 100%, I think we should look at pharmaceuticals. Because like I said, within my practice, and really most primary care practices, so your family practice doc, your pediatrician, nurse practitioners out there hanging their own shingle, the problem with prioritization, 90% of it is with pharmaceuticals. And that's where our delays come. It was like the example I made of the young man who, right now is not even able to be in school because he's too disruptive. So he can't have, because he's not getting the meds right now that work control him. So yes, I think 100% we need to. I think it's a way that we make sure people get the proper drugs. I know the argument's going to be, well, some of these drugs are so expensive, and yes, but we're not asking for experimental drugs to be, in this process, those kind of things. We're talking about tried, true, proven medications that are life-saving and that are life-altering for people like our patients. So yes, I definitely think we need to consider that in this bill here. The other thing I'm not, I really learned a lot from the Louisiana commissioners talk and enjoyed watching it and rewatch parts of it. And every state's going to have to come to their own approach. I feel like something maybe a little more structured would serve us better than what they're doing. And I think eventually they're going to have to bring theirs into something more structured. I can't see how they can manage if every insurance there came up with a different plan that they're going to be able to govern and maintain all of those. There's going to have to be a common ground in there. So I would like to see us do something that's a little more thought-provoking and more structured than that.
Hill?
Yeah.
Appreciate you coming to speak. Apparently this is state to state to state having the same issues. I wasn't able to hear the Louisiana presentation yesterday, but my insurance is it's administrated out of a different state than Mississippi. It's a Blue Cross policy out of another state, but I have never up until this past year had procedures denied, like MRIs denied, even after an x-ray is done. And they want you to go to 6 weeks of physical therapy, not knowing if you've got a torn rotator cuff or what's wrong with the soft tissues in your body. So I've experienced this, and it was so bad with my husband that I actually had to find somewhere to get an MRI and pay cash. And people don't know to do that, and they'll continue to suffer and create more damage if they do go to physical therapy. My physical therapy wouldn't touch my husband. Known him for my whole life. And he's like, I'm not touching this arm unless I get an MRI. The surgeon at Mississippi Sports Medicine said, I'm not touching this arm until I get an MRI. But the insurance company said, oh, go to 6 weeks of physical therapy, then we might approve the MRI. So, that's where we are. And if I'm dealing with this, the general public is dealing with this. And I've also had numerous calls about prescriptions, like you say, and some on the state insurance plan through teachers and other people that they've had this medicine for years and years and years, and then all of a sudden they can't get it and have to have a pre-authorization, and then they're out of the medicine for days. I've had to call the commissioner's office for help. So it's a huge problem. And if people are paying their insurance premiums, my opinion is they expect to get the service, and they expect not to have to fight to get what they've been getting or what they need. And these stats from the Board of Medicine. I mean, that shows you that people are having worse outcomes because of the delays. And I feel like my colleagues have probably experienced the same thing. I know we want to hold costs down, but we want the insurance to actually work for the patients. And that's kind of where I've been trying to navigate for patients and for myself.
Oh, thank you for that, because it's just another example. And the one thing you pointed out, you or I are able to pay for that MRI, but a lot of our patients are not. And so when those delays with them, they don't have any choice but to wait, which is asinine. And this is a trickle down. Well, I'm not gonna say trickle down. It's a trickle out problem. We've had it a little bit longer in Mississippi than some of my friends who practice in Louisiana or Texas or Tennessee. Heck, when I get a patient in, it says on my ticket what their insurance is, just because you have to know that, because I have to know, oh, I can't do this on this patient, or I can do this on this. And I mean, I jump for joy when I see they're from Tennessee or Texas or California.
Well, and I also want to say that our provider went through the appeal process. Our nurse practitioner went through the appeal process, which was a joke. And then we just chose to go on and see somebody anyway, and then had to navigate that. But that cost him a month of hurting, or 6 weeks of hurting. And finally, I'm like, okay, we're not dealing with this anymore. And I didn't have just, $1,000 laying around either. But at that point, my husband being a cancer survivor and having another joint issue, I'm like, okay, well, we're going to get this one way or the other. I'm not waiting 6 more weeks and putting you through this. So I just say this to reiterate that the public is dealing with this. If I'm dealing with this and I'm to the point of frustration and exhaustion on dealing with it, the public is much farther along than that.
Well, like I said, that 40 PAs a week per provider, that's 40 patients per provider. And so a group like mine with 11 partners, do the math. That's a lot of patients that are not getting what they need every week.
Dr. Frawley, I'd like to ask a question. We can understand examples like orthopedic issues, a hip replacement or torn ACL. Those are very expensive issues. Give us some examples of what you deal with in a pediatrics on prioritizations.
Yeah, I mean, the biggest ones, like I've said, are medicines, but they're not. I'm not writing anything that's $1,000 a month. I mean, a lot of the times the things I'm having to get prior authorizations are medicines that are $30 for the single prescription. That kind of thing. Some of my families can pay that, some can't. So we have to jump through those things and do it. That's the biggest. I mean, I do have to order CTs for things like, the kid that comes in with right lower quadrant pain. I'm the person who makes the diagnosis that they have appendicitis. Well, a lot of those, if my exam is strong enough, then I feel like, they're imminent, that, rupture's there and I need to get my image and get them to surgeon. So sometimes what happens is if the prior authorization is going to take a while, the only way I can get that person taken care of in a timely manner is to either supplant the whole thing, call the surgeon, get them directly. But most of the time to get it covered, I have to send them to the emergency room, which is I don't need the patient doesn't need the ER. I don't need the ER to make the diagnosis. I need an image, which is simple, and get them on. And this is something that's, $400 or $500. I mean, there again, we're not talking about a hip replacement or I have a son who had a 12-level spinal fusion. That was $236,000 5 years ago. So, I mean, I understand those, but we're talking about in the primary care world, really things that aren't that expensive, but that are very important.
Chairman Zuber.
Thank you, Mr. Chairman. Doctor, thank you again for your time and your testimony. You caught my attention whenever you told us about the example where you're operating on somebody and you find something else that needs to be done, and you have that 24-hour deadline to get your request for approval in. If we look into that, what would be your recommendation? How long would we extend that deadline?
Well, that's something we'd have, in all honesty, we'd have to work with our surgery guys within the group and talk to you guys and see where that should be. Not being a surgeon, I would have to kind of get the numbers and look at that. But I mean, obviously a week, something along those lines, I would think, but I would really want to look at the statistics and get the, the opinion from the people who are dealing with that every day.
Thank you.
Sure.
We sure thank you so much for your time today.
Thank you guys so much.
Thank you for being with us.
All right, thank you.
Okay. David Roberts, would you please introduce our next speaker?
Good morning, Senator Michelle, Mr. Chairman, Chairman Zuber, Chairman Michelle, and members of the committee. It's my pleasure this morning to introduce our next speaker, Dr. Clay Hayes. Dr. Hayes is a board-certified interventional cardiologist and president of the Jackson Heart Clinic here in Jackson. He received his clinical training at UMMC, Harvard Medical School, the NIH, and the Mayo Clinic. Dr. Hayes also received his MBA from Brandeis University in Boston and has served as the past president of the Mississippi State Medical Association and currently serves in various leadership roles in the American Medical Association. Dr. Hayes has served as past chair of the Greater Jackson Chamber Partnership Board and continues to serve in leadership roles on the MACM Board locally and also the Trustmark Bank Board here in Jackson. He's overseen the growth of Jackson Heart Clinic for the past 25 years. They now have offices in Jackson, Flowood, Madison, Brookhaven, and Ruleville. Please welcome Dr. Clay Hayes.
Dr. Hayes, I want to thank you also for your commitment to providing health care in the state of Mississippi. And
Thank you, my senator.
thank you. Proud to have you as a constituent.
Yeah, I appreciate that. You know, and I have many friends here. Obviously, I look on the committee and in the room, and I appreciate everything that y'all do because it is a challenging thing that you do, and I appreciate the service that y'all provide. I've actually been in practice now for over 25 years, and I love Mississippi, and this has been my passion for so long. You know, whether it's the community here in Jackson or throughout the state, that's one of the things that I wanted to see happen. When I first started practicing, we were only in Jackson. And we realized that the population of Mississippi was growing and that they needed services elsewhere. So that's why we go to these places. We're building a new office in Rankin County because of the services that are needed. We're going to expand our operations in Madison. We've been down in Brookhaven. As David said, we're up in Ruleville now because there are so many doctors that have either retired or left, or hospitals that are having a challenge. And so we need your help to help these people. And that's one of the reasons why I'm so passionate about this particular topic. The State Medical Association House of Delegates passed 2 resolutions, one last year and one this year, about this particular topic. The AMA, I represent the Southeastern delegation to the AMA House of Delegates, and this is the #1 goal for the AMA for this year, to try to help physicians. So this is a huge topic for many, many physicians across America. So I appreciate that very much. And by the way, the State Medical has provided slides today, and I'll go to the next slide if we can, or I can do this now. So it's all about access to care. And really, it's all about trust. You should have a copy of these slides in front of you. So, I mean, when you think about it, trust is the foundation of all great organizations and relationships. We trust our families, we trust our religious organizations, our business relationships, and you, our governmental officials. Trust is the core element of the physician-patient relationship. When a person gets really, really sick, they go to the doctor and they go to the hospital to get help. They trust that they will find what they need to get better. Why else would they go there if they didn't trust? And so when a patient or business pays their health insurance premium, they also trust the insurance company or third party will help them as well. They are reminded of this every month when they pay their premium check. And so, and that has an effect on the care delivery. You can see half the physicians report that their care delivery is affected and sometimes can lead to a serious adverse event, and we don't want to have that problem. And so when I look at it, prior authorization is a lack of trust. It signals to the patient that they don't trust your physician to do the right thing. Despite all the training that we have, the board exams that we've passed, and the hours that we've spent helping people, third-party payers still want to make sure that physicians know what they're doing, except, of course, in emergencies. Now, let's think about that. So somebody comes, to the hospital, they're at the highest risk of having a bad outcome, and there's no need for prior authorizations. The medical delivery trusts the physicians to do the right thing. Physicians haven't magically changed. They're the same people. It's just the circumstances have changed. For example, the patients trusted us when the pandemic came. They trust us now when they come to the hospital having a heart attack or a stroke. They trust us in delivering their babies or when they need a surgery. So which is it? Do you trust us or not? Good docs want to do the right thing. So what is the argument for prior authorization? We all know that the cost of care, of healthcare has gone up and continues to go up. And prior authorization was designed to lower costs, which is a good thing. It was designed to eliminate wasteful spending. It would blow up the mountain of bad acts by all physicians. The challenge with this type of thinking is that the vast majority of physicians do the right thing. Most prior authorizations requests are approved instead of denying care. Prior authorization, all it does is delayed care. And then the concern comes up about what do the patients think? They say, well, if it's just so, bad or whatever, they'll delay or they'll quit the treatment, which is a bad thing. For example, I have a patient that I've been treating for the past 15 years. He has heart disease, and I put a couple of stents in him to help him with his coronary artery disease just as he was getting ready to have a heart attack, and we stopped his heart attack. He's done everything that I've asked him to do. He's followed a proper diet. He doesn't smoke. He exercises on a regular basis. He takes his medicines. He does everything he can to try to help himself, but his cholesterol is too high, and I worry about it. I've been taking care of him for 15 years. He's not only my patient, he's my friend. And so he asked, like good patients do, what else can I do to be proactive to head this off? And I said, well, the only other thing I can do, you're already on the standard guidelines of care of cholesterol medicine. You're on a statin and you're on Zetia, but yet your cholesterol is still too high. And I told him that there are some other medicines that are available now that are out FDA approved, that they are expensive, but we should try to see about getting you on one of these things because it should help you lower your cholesterol. But then, here we go, the negative impact. So because of this cost of medicine, his insurance company requires us to do a prior authorization. I filled out the 10-page form that went along with it. I got, giving his history, what medications he's been on, what doses he's tried, what are his lab values. I faxed the form and waited 10 days. We were sent back a letter that he was denied, so I asked for an appeal. They wanted more information justifying my request for the patient. I provided it. Then the patient called his insurance company. I scheduled a time to personally chat with a physician that was in Colorado. I scheduled this time. I finally got him on the phone. We went over all the stuff, and guess what? He got approved after 30 days. Now, is that a good use of my time, my staff's time, the patient's time? I mean, that's not a good idea. What's the cost to my practice and what's the cost to the patient and society? So how many, as Dr. Chevalier had mentioned before, what are the number of PAs that we complete every week? I have 2 full-time people in my practice that they do nothing but prior authorization. And they can't get enough done, so we have to sub it out to a third party. My nurse deals with this every single day, trying to make sure that they do. I mean, I kid around, I say cardiologists, we practice medicine, we do imaging, we do procedures. We're like kudzu. We can do a lot of things and go everywhere. I mean, that's one of the things that we do. And so I'm not saying that all health insurance companies are bad. They provide a wonderful service for employers, patients, and the community at large. They're excellent at managing risk, and they understand how to manage capital. They promote health and wellness. They negotiate drug prices for their members, and they sponsor numerous community programs that benefit society. That is good, and we thank them. And this again goes back to the hours that we spend. So what is the cost of delaying care? Physicians have to hire more staff just to do the paperwork of prior authorization. And so here it is, 33% of physicians have staff that work exclusively on our prior authorizations. So what does this cost? Patients want to get well quickly, but they have to go through the stress and anxiety of waiting for the treatment. What does that cost? Employers have to wait on their sick employees to get their treatment. What does that cost? Families have to juggle their schedules and to take care of their loved ones, to make sure they have arrangements to get them there. What does that cost? These are all societal costs that everyone has to bear, not just the third-party payers. We believe that Texas and other states have figured this out. Why delay care when the vast majority of physicians do the right thing? We understand that payers want to have some sort of checks and balances to help manage their risks. So do we. We believe the proposal set forth that checks us retrospectively provides that assurance. If physicians pass the prior authorization test 80% of the time over the 6-month period, let us have the gold card of excellence to facilitate faster care. Show us that you trust us. Let's put patients over paperwork. I'm happy to answer any questions that you might have. Thank you.
Hill.
Just want to make one question or comment to you. When you get these denials on some of these treatments, maybe a very specialized treatment like proton radiation or an MRI on somebody's shoulder or a knee, is it surprising to you that these doctors that are contracted to do these appeals are not even in the related healthcare field that these procedures deal with?
I'm not surprised by that. Like I said, I've talked to physicians all over the country, and these physicians on the other end or on the other line are typically very nice people, obviously very knowledgeable, but sometimes we have to educate them and explain to them exactly what's involved. And then, just like Dr. Chevalier said, they say, oh, that's very reasonable, approved. And so we, again, I cannot remember the last time I was denied care of when I did a prior authorization request.
Well, the appeal that was denied recently back in April for my husband's MRI, the denial was done by a pediatrician, not an orthopedic surgeon, not a sports medicine, but a pediatrician was the one denied the MRI on my 61-year-old husband who is a cancer survivor. Just thought I'd make that the icing on the cake.
Dr. Horn?
Thank you, Thank you, Mr. Chairman. Dr. Hayes, I joined the chairman in our appreciation of your service to the state. Can you identify any negative outcomes to your patients that have resulted from a prior authorization that came too slowly?
Definitely. And so, for example, as I mentioned, I go to Louisville to an office up there to try to help the physicians there. We had a cardiologist in Greenwood who referred me a patient that had aortic stenosis, which is like, if you have severe aortic stenosis, which is a narrowing of a heart valve inside your heart, your chance of survival over the next 2 years without treatment is only 50%. That's like a cancer diagnosis. So that cardiologist in Greenwood identified this appropriately and did the workup, but he couldn't do the procedure in Greenwood. So he said, can you help me help this patient? And I said, sure I can. And so we worried about the challenge of getting them down to Jackson. So I said, well, look, I have my office in Louisville, have them come over. It's not very far. We can talk about these sorts of things. So he sent them over and said, well, what can I do to help? And so I said, well, you need to have a heart cath. You need to have a transesophageal echo. You're going to need to have surgery or some sort of procedure to fix this problem. Okay, so we start that process and we get going, and the insurance company says, I don't know, they've already seen by a cardiologist, they've had all this workup, I'm not sure that they necessarily need this. And I'm like, this is guideline-based care, what are you talking about? Well, we got to make sure it can be done at the right hospital. Why couldn't they do it in Greenwood? Why can't you do it in Louisville? I said, Louisville doesn't have a heart surgeon. I mean, come on, what's going on there? So all these delays in care. And so what happens? The guy, ends up, because it took us, 30 days, the guy, he's had symptomatic aortic stenosis. He had a heart attack and he winds up in the emergency room, almost died. Definitely has permanent damage of his heart. Fortunately, we were able to fix his problem, but it was the delay in care that we saw that, that's a problem. And that's what gets us so fired up. And doctors are super passionate about their patients. We love our patients. And if we can't do the right thing, it's so frustrating for us. I mean, we went into medicine to help people, not to be denied. I mean, come on. I mean, how much more do we have to do to prove ourselves? I mean, we talk about football. You make Tom Brady have a prioritization before he goes out on the field, tomorrow or last night. I just think about all these things, that how well we are trained, how long we've done. It's not like the physicians are bad people. Again, I use the example for emergencies. You're going to make us have a prioritization when somebody comes in with a heart attack? I mean, come on. I mean, this is what this is about. Again, it's putting the patients over paperwork. And you can tell I'm getting all my blood pressure up. I'm getting really fired up about this. I think about that. I mean, I went to the hospital this morning to make sure that the patients got taken care of, that they got what they needed, because they came in last night at 1 o'clock in the morning, and I had 4 heart attacks that came in the hospital last night. And instead of me being there to take them, I made the arrangements so my partners can take care of them in the cath lab today. We have 25 people going to the cath lab at St. Dominic's. There is a tremendous problem. It's the #1 killer in America. And of course, Mississippians, heart disease. And so you're going to say, what? You don't know what you're doing. You're not providing guideline-based care. I mean, come on. I mean, what do we have to do to help people? This is what gets me. I'm getting all fired up.
So
anyway,
before you get too much more fired up, Which is the Louisiana model, the model that you would recommend, or is there another state that has a good model?
Well, obviously, I like the Texas model, but I think there are a lot of good models that we need to look at. I think obviously Louisiana's trying to figure that problem. I've talked to the folks in Kentucky, the legislators up there, and I have some names if you'd like to have that. But I think that the making sure, and the question came back, is it just medicines? And no, I think it's medicines. I think it's imaging. I think it's procedures. All those things need to be looked at. So that's one of the things I think is really, really important.
Thank you, Mr. Chairman.
Vice Chairman McClendon.
Thank you, Mr. Chairman, and thank you, Dr. Hayes, for being here. Physicians require a Mississippi State health or a doctor's license. physician's
License, right, absolutely.
So the doctors that work for these insurance companies, do they have a Mississippi license?
That's a question. I don't think so, but I don't know. I don't want to tell you something I don't know.
Do we require that as a state?
Let me ask, on prior authorizations, you've mentioned the examples where you're dealing with another medical doctor. Is there ever a time where you're dealing with someone in an insurance company that might be clerical and not have a medical degree?
Well, I mean, when we first start out, it may not be a nurse practitioner. I mean, a physician, it may be a nurse practitioner or a nurse when we first start that process and they don't understand. And that's why they kick it to the appeals process. And I said, look, with all due respect, I don't think you understand, this, part of the procedure or what medicine or what have you. And so it's the appeals process to get to the physician. But the problem is they may be in a different state and a different time zone, and you're trying to coordinate your schedule with their schedule. And so you may have to stop between patients, call them, hey, can we do this? Or, they're trying to use Zoom calls or whatever too. So that's the challenges we face. It may be in a different time zone that we're not dealing with the same, with that's the challenge for us.
Any other questions? Dr. Hayes, thank you for giving of your time with us this morning and being with us. We sure appreciate your knowledge. And we really appreciate you being with us this morning. Thank you.
Service as well. Thank you very much.
Thank you. As I mentioned, this issue is growing and growing and growing and growing. And many states are going to have legislation this year. And several of us will be going to New Orleans in November for NCOIL, National Conference of Insurance Legislators. That's where we first heard about the idea. Chairman Zuber was there with me, Ford, and I know Nicole Boyd was there, Senator Boyd. And they're going to have additional hearings on it. And so we'll have an opportunity to hear from some of these other states, some of the other ideas they have as well. So we had experts here today, and we're going to hear from additional experts from all over the country. Thank you all so much. Okay. Another very important issue before us is our state and school employees' health insurance plan. We talk about providing medical care. We have several 100,000 people who all live in our districts that we provide health care for. It's important to understand that our state health plan is self-insured, and our state plan management board hires a company to handle the billing, and a company also to be a pharmacy benefit manager, PBMs. We heard from several PBM on the issue last month. And with us this morning is Ms. Cindy Bradshaw, and I saw Liz Welch was here. Did Liz leave? Liz is Director of Department of Finance. Liz chairs the board. Cindy is the expert in the Department of Finance on insurance issues. I want to say that I'm so thankful that the way the legislation is set up is that the two chairmen of Insurance Committee in the House, Insurance Committee in the Senate, serve on oversight of the board, and also the two appropriation chairmen, excuse me. And that has helped me tremendously to understand how this program works and to stay on top of the issues that are before us. So the things that Cindy's going to talk about this morning, I've had the pleasure of hearing over the last couple of months, and she wants to give you an update. And this is your chance to ask any questions about our state plan. Why do we hire a pharmacy benefit manager? Why do we hire somebody to do the billing for us? Cindy, thank you so much for being here with us this morning.
Thank you. Thank you. Thank you,
Chairman Michelle and Chairman Zuber, I appreciate the opportunity to give y'all an update on the health plan. Just kind of wanted to reiterate some of the information I shared with y'all last year, that the state does have a statute that gives the authority to the Health Insurance Management Board to make the rules and regulations for the plan. They set the coverage that is provided. We adopt a strategic plan on at least a 5-year outlook on what our goals and objectives are. And it's the oversight is the Health Insurance Management Board. The day-to-day operations are housed in our Office of Insurance, which is a division of the Department of Finance and Administration. Just wanted y'all to have a list of the members who are on our board. As you mentioned earlier, Liz Welch is the Chief Fiscal Officer and the Executive Director of DFA, and she serves as Chairman of the board, as well as most of the other agency heads and elected officials. By statute, we also have an advisory council. We meet with them to discuss potential benefit changes. They make a vote recommendation on that. We take that to the full board before we enact any changes. So who's covered by the plan? We have all the agencies, school districts, the community colleges, the libraries, universities, the House and Senate employees, as well as elected officials. And as Senator Michelle said, we are self-funded. That means that we collect the premiums, we keep those in our house, and we pay Blue Cross and Blue Shield as our vendor on the medical side, and we just reimburse them for the claims that they pay, as well as the same on the PBM side with CVS. We do not receive any direct appropriations from the state. Currently, we have about 190,000 covered lives, 107, a little over 107,000 active and COBRA employees. And we have about 52,000 dependents. We have 18,000 Medicare retirees, plus a little over 3,200 dependents on that, and a little over 7,000 non-Medicare retirees. We have two different classes of employees that, as a result of legislation that was enacted back in 2006, anyone who was employed by the state prior to 2006 is considered a legacy employee. Anyone who's employed after that is a Horizon employee. The significance of this is basically on deals with our OPEB liability, and we'll look at that a little bit later. So we do have two different coverage options. We have a select coverage and we have a base coverage. The base coverage is statutorily required to be at zero cost to employees. It's considered a high deductible health plan, and one can get an HSA for participating in that coverage. We also have the select coverage, which is deemed a little bit higher level of coverage. I think the most that employees pay for that now is $43. Currently this year, the deductible is $1,500. At the board meeting last week, the board did vote to increase the deductible to $1,800 starting January 1 of next year. This slide just kind of gives you a breakdown of what the difference between Horizon and Legacy and which coverage option they choose. We've kind of tipped the balance a little bit now, where we have more Horizon employees and less Legacy employees. And we can also see a big difference in the retiree coverage. We have Legacy employees, statutorily, their premium is set for retirees to be only 115% of what the active employees are. Horizon employees have to pay the actuarial value of it. So we have fewer people, Horizon people, taking the retiree coverage. This page kind of gives you a representation of that. So as the Legacy employees decline on the retiree coverage, the state's OPEB liability, which is currently over $643 million, it continues to drop down as more Legacy employees roll off the retirees coverage. So the state pays a full cost of the coverage for active employees enrolled in the base coverage. Again, you can choose to select coverage and pay the applicable premium for that. If you're a legacy employee, you only pay $20 a month. If you're a Horizon employee, you currently pay $43 a month. I can tell you that beginning January 1, those rates, we have notified ELBO that the board did vote for a 6% premium increase January 1. And right now the projections are a 7% increase for 2024. So the employee pays the full premium for dependents, and then the retirees pay the full premium for themselves and the dependents. I've included in here just for reference for y'all what the premiums are. This again is just a snapshot of the increases, the premium increases that we've had over the years. I mean, you can kind of notice that they've steadily kind of gone up, but from 2011 through 2018, it was relatively flat. We went for 7 years without having but one increase. And then in the last 4 years, we've had an increase every year. This slide is something y'all had some interest in last year. I think there was a good bit of discussion about the cost of the family coverage, and I just wanted to share this, and at y'all's suggestion, we'll add a little bit more information. So if you look at the very first column at the total cost of what the total cost of providing insurance for our employees, Mississippi's cost is $211 less than what the average is for other states. The employee share, if you look at the premiums for the employees, our employees here pay on compared to the average $50 less than the other states. The state's portion of the insurance premium is $162 less than other states. Family coverage is $468 less than other states. The employee share, because the state does not contribute anything to the family coverage, the employee share for family coverage is the one that's kind of high. And our employees for family coverage are paying $317 more than what the average is for other states. So if you look at the next to the last column, the state share. So the state share on average for what you would pay for family coverage is $786 less than what other states pay. So one reason why we're having rate increases is because our population continues to utilize the services a lot more. We have two major factors. We have more people utilizing services, and the cost of pharmacy benefits continues to increase substantially. I think Senator Zuber referred to this in his last hearings too, that the last 10 years on a PMPM basis, the cost for providing pharmacy benefits has gone up 60%. So this slide just kind of shows you, you can see the difference, especially between 2019 and 2021, the drastic increase that we've had in treating cancer, cardiovascular disease, arthritis, diabetes. In the top 4 conditions alone, we had an increase of 6% just over the last 2 years. So the state also has a program that's considered our wellness program. It's called Keys to Living Healthy. So there's a couple of things that, we do here. We're trying to encourage people to have positive health outcomes by participating in health and wellness programs that we offer, and then also to help reduce healthcare costs. Some of the components of our wellness program is that we've implemented an incentive program this past year, and for any members that will complete this program, which is pretty simple. We ask you to register for Active Health, who's our wellness vendor. We ask you to complete their online health risk assessment, and we ask you to have a wellness visit within the last 2 years. If you've completed those 3 things, starting at the beginning of next year, your deductible will be reduced by $300. I mentioned earlier that the board did vote to increase the deductible by $300 beginning next year. So in the next incentive program starting in January, if one completes the incentive program, they will have the ability to bring their deductible all the way back down to what it is today and not have that increase. As of today, though, I mean, the people who have participated in it is a little bit low. We only are seeing about 5,000 people at this point that have completed the incentive program that will get the $3,000 deductible next year. So just as a plug, you haven't, if there's any state employees in here, you have until the end of this month to complete those components. So we do cover an annual physical once a year at 100%. We also offer through our Wellness Vendor Active Health, weight management, tobacco cessation, and a maternity management program. And then we also have worksite wellness coordinators. We have 4 of these strategically placed throughout the state. Their role is to go to the schools and the agencies and to help promote health and wellness activities. They have lunch and learns. They may help sponsor a run, a walk, that sort of thing to help employees get engaged in creating healthier outcomes. I wanted to switch over just a little bit and talk about the gold card bill and just give y'all a little bit of information about what we do on the state health plan side. So we do have a contract with a company called KeyPro. It's Keystone Peer Review Organization. And they are charged with ensuring that participants receive medically necessary care delivered in the most appropriate setting, and that they are following generally accepted medical guidelines. Utilization review provides a clinical review and certification based on medically necessary care. So I think it's important to note that these are the services that we require have to have a prior authorization. We don't require prior authorizations on MRIs. We don't require prior authorizations on X-rays. We don't require prior authorizations on any outpatient services. So the ones that we do are listed here, and we have over the years, I mean, the prior authorization administrative burden also lies on us. Once a physician submits that information, the insurance plan has to review it on the back end. So we are constantly looking at those services, and Blue Cross has published their medical policy online for physicians to go and look. I think one of the reasons why some physicians have high thresholds of approval is because through that process, they know what's covered and not covered. They know what needs to be submitted in order for it to be approved. So you're going to have higher compliance rates with that. The services that we do require prior authorizations are often complex cases. This gives us an opportunity, once they're notified, for us to have a case manager assigned to that person to help them and walk them through. They'll have a nurse that walks them through the transplant if they need a transplant. We have, the only outpatient procedure that we have a PA on is bariatric surgery procedures. That's very intentional. One of the things that we want to try to determine in the front end process is, has that member made the lifestyle changes that they need to make for their surgery to be successful? If they haven't started exercising, if they haven't started trying to lose weight, if they haven't started eating a healthy diet, having bariatric surgery is not going to help them. They're going to have the surgery, they're going to lose a little bit of weight, and then within a year, they're going to start gaining the weight back, and you put them through a risky procedure for nothing. So that's our goal in having a PA process on bariatric surgeries. There's a lot of emotional and psychological impact to having that surgery too. So we want to make sure that they've had the appropriate counseling and that they're mentally prepared, because it's a huge change for these patients. So, I guess I kind of stand here from a different perspective, because I'm not getting money. I'm not in the business of making money. I'm not running a business like a physician is. I'm not on an insurance side where I'm Blue Cross and Blue Shield trying to, to trim down. So I think I stand in a position to be a little bit objective about this. And so, I think with the gold card, what we do is that we're going to shift a lot of that administrative burden from physician's office over to insurance companies' offices, which is going to cause their premiums to go up. I don't know of any insurance product that does not have check and balances in there. I mean, if you have damage in your house and you need to get your property insurance company to pay a claim, there's going to be some checks and balances there. If you have a car accident and you take your car in to get it fixed, there's check and balances. Insurance company is not going to pay $3,000 for a $2,000 repair job. So I think this is, a unique opportunity for us to look at this and just make sure that if there are modifications to it, that we just get it right. I think in the absence of having some prior authorizations, you're giving physicians unfettered access to the state's checking account. There was a provision in there that said if they had been approved for the gold card, that you couldn't retract any money back if they did something that was outside the medical policy. And, we do audit already on the back end. And, I can tell you from January through the end of June, we've already reviewed claims and have retracted over $1.6 million. And that's just on hospitals. That's not on physicians. And that's simply with hospitals upcoding claims that when the coders get the medical records and they look at it, they have a discussion with the hospital and say, you've coded for high complications. There's nothing in the records to indicate it's a complication. At that point, the hospital will submit a corrected claim and there's a lower reimbursement for it. So there's a substantial amount of money on the back end that we audit for. There was I think some ambiguity, at least in my mind, as to whether the bill that was introduced last year impacted pharmaceuticals. I think that's something that needs to be clear. And I think that's probably, a big pain source. If there is one for the state health plan, it's prior authorizations. And so I just want to leave you with this example. And we did an audit last year on medical claims for people who were getting their prescription Ozempic. And so the state health plan does not cover weight loss medications. Ozempic is FDA approved for treating diabetes. When we took a sample of people who had prescriptions for Ozempic, and we looked in their medical records to see if there was a diagnosis of diabetes anywhere, 48% of them did not have any diagnosis in their medical history, which said to us that they were prescribing this for weight loss. When we extrapolate that to what we paid for Ozempic in those last couple of years, it could be easily in excess of $10 million. So we implemented a prior authorization process. We want physicians to attest to the fact that these patients are diabetic. And we've automated that process so that they don't necessarily have to submit a PA. We have CVS has a system where the first line of care is to give patients metformin. So if within the last 180 days, a patient has a prescription in their history for metformin, and then a claim comes in for Ozempic, it's automatically approved, and the physician doesn't have to do anything. But I can tell you, we already have 3 cases that we're looking at right now where it looks like physicians have submitted a claim, or the patient has filled a prescription for metformin for 1 month, and the very next month they're back on Ozempic, and there is still no claim in their history for diabetes, and the physician's offices have figured a workaround around that. So that's something, we're going to have to look to tighten up, because that's a substantial amount of money. So I know there was reference made earlier too about changes in formularies without there being notifications. We did change to a more restrictive formulary effective July 1. We started sending letters out to patients. It was 43,000 patients that we sent letters out to, advising them. And I know there are people in the room that got those letters. We also had listing of impacted members that were sent to the physician's offices. We also had a clinical pharmacist that was traveling around talking to physician's office to prepare them for the change. And so, in our defense, I think we've submitted ample notification when, and that's a requirement of our contract with CVS, that anytime there is somebody that's going to be impacted by a formulary change, that they send out notifications to the members and to the physician's offices. So secondly, I just kind of wanted to see, these are statistics. We have a performance guarantee in our contract with KeyPro that they complete 99% of all pre-admission reviews within 2 business days. And so you can see here, we've got first, second, and third quarter. They had 100% within 2 days in the first quarter, 98.8, 99.5. You know, I've been with the state for over 10 years now, and I think I've had 2 cases of a member that's called me that said they were concerned they were not able to get the services that they needed and their PAs had been denied. In both of those cases, I'd had a conversation with our utilization management, had a conversation with the doctor's office and the member, and the doctor's office did not submit appropriate medical information for it to be covered. Once that information was submitted, the PAs were approved. I also have had a couple of cases where we've talked with medical directors, and, you know, prominently one is back surgery, you know, and the medical director will talk with the doctor, and, you know, in 2 cases, the doctor has just said, the patient has pain, we don't know what else to do, so we're going to do a fusion. I mean, that's something you can't reverse. And if it's not medically necessary, in a lot of those cases, the patient's still going to be in pain. So it provides a lot of safeguards and protections for the patients as well. The next item I just wanted to talk about was yesterday, there was some discussion about breast cancer screening and expanding the services that plans would be required to pay at 100%. And I just wanted y'all to take a look at this, because we do have a state mandate that we cover mammograms annually. And I think we start covering them at age 35. So our guidelines typically is that we are required based on ACA to cover any services that the U.S. Preventive Task Force gives an A or a B recommendation. And so just by way of background, the tax force is a group of doctors, various specialties, various scientists, and they are looking at and reviewing any medical studies that are going on, and they look at whether this is harmful or beneficial, and they make a recommendation. So if you look at this slide, their recommendation for any women, they don't recommend for women under the age of 40 to even have a mammogram unless you have a family history or some other reason that you would actually need one. I think the third box down kind of gives you some definition as to when they think it would be recommended. But even for women between the ages of 40 and 49, based on their studies, it's a C recommendation. So they don't even that's not a high recommendation for women to even get mammograms between the ages of 40 and 49. They do give a B rating to women having mammograms between the ages of 50 and 74. And again, that's not annually. They recommend that it only be done every 2 years, because they don't think that the risk associated with having a mammogram and having potential follow-up biopsies and stuff as a result of a lot of false positives outweigh the benefits of it. And so it's even at 50 to 74, it's a B recommendation. And then for women over the age of 75, they don't recommend that women have it at that age. So we have a little bit of disparity between what we're required to cover at the state and what we are actually, you know, the evidence, the medical evidence supports that should be covered. So after the topic of conversation yesterday, we went back and tried to slice and dice some of the data, and, you know, just on MRIs alone for breast cancer, it was in excess of like $26 million. And so it's a tremendous amount of data. I'm going to go back and at least try to give y'all some better information if we were to expand it, how much that would cost, but I think it would be substantial. But I think also the thing that we need to look at is, you know, breast cancer is one type of treatment. Then if we do it for breast cancer, should we not do it for colon cancer? Should we not do it for pancreatic cancer? Should we not do it for brain cancer? And I think it just opens up a Pandora's box that anybody who's going to get any diagnostic testing for any type of cancer is going to want it to be paid for at 100%. And, I'm a member of the state health plan too. I mean, I'd love for all my services to be paid at 100%, but, at the same time, there's substantial pressure on us to be able to provide services for everybody at a reasonable cost. And a lot of pressure on us to mitigate the rate increases that we're having. I mean, we certainly recognize that a 3 to 6% rate increase has a huge impact on the state's budget. And so, we're always trying to balance with that, making sure that we can provide services to everybody who needs those and that we do it in the most cost-effective manner. I think there was also some questions about the Blue Card program yesterday, and I did want to just kind of offer a little bit of insight on that. And so, each Blue Cross and Blue Shield in each state is independently owned and operated. They determine what their rates are. They determine, for the most part, what the medical policy is. I think now there's more of a trend to follow the National Association's medical policy with a few deviations between there. But so the arrangement used to be, and I can tell you that prior to 2014, if a state health plan member went out of state, they didn't have any network benefits. And so Blue Cross and Blue Shield would pay those claims based on the rates that we had here in the state, whatever our network rates were. And the member was held accountable for all the ineligible amount. So for example, if you were in Colorado and had a biking accident, you could walk away having a tremendous amount of expense after the state health plan paid their part. So we worked with Blue Cross and Blue Shield to implement the Blue Card program. And the first year that we implemented that, our medical claims went from 574 million to 513 million the following year. So we saved $61 million by having the Blue Card program. And so what that says is they all kind of form this agreement that says if one of your members is in our state, we'll let you have the benefit of our network. You just have to pay our provider what our contracted rate is with them, because that provider has a contract with Alabama. That provider, if he's in Louisiana, has a contract with Louisiana. I mean, so that's the rates that have to be applied. So, and it goes both ways. I mean, we look at it from comparison sometimes when we get our bill for the Blue Card claims, sometimes we pay less if the member goes out of state. Sometimes we pay more. But, the cost of living and what they pay providers in New York is substantially less than the cost of living and what we pay providers here. The same thing in Birmingham. The cost of living in Birmingham is a lot more expensive than what it is here. But that's kind of how that arrangement works. And if there's any other questions about that, I'd be happy to entertain that.
Question on a different subject.
Okay.
Are you through with your presentation where we can ask you other questions? Thank you. Mine deals with the fact that this is an obligation of the state of Mississippi, and we had significant payouts for COVID claims and the stability of our cash position to make future claims. The American Rescue Plan Act funds, we were able to contribute $60 million to the plan. Can you please document for us the amount of payments that you relate directly to COVID claims?
Yes, sir. So the last total that we had was in excess of $140 million. So that started, those numbers were generated from when COVID started in March of 2020. So with the new funds, there was a limitation in it that the time period couldn't start until March of 21. So we can't include a whole year's worth of claims and from that standpoint. So I just got the revised figures from Blue Cross and Blue Shield this morning. And from March of 21 to the present, we're still in excess just on the medical side of over the $60 million. So we still are waiting on the same evaluation from CVS And then the life insurance claims, we still know that we've paid in excess of $5 million in life claims that were COVID related.
Senator Harkins?
Thank you. Thank you, Ms. Bradshaw. Can you elaborate on something you were touching on about Ozempic and its being, I guess, prescribed off label for weight loss? There are drugs now that are FDA approved for obesity treatment. Is that
There
correct?
Ozempic has, they rebranded it under the name of Wegovy. And physicians could write it for Wegovy, and we know that that's FDA approved for weight loss, and we could automatically deny it.
All right. Do any other states cover obesity medication that you know of?
I do know that there are other states that cover it. I'm not sure which ones. I would be sure that California covers it.
I think I heard Tennessee may cover it. I know the federal insurance program, I think, is mandating they cover it for federal employees. One of the things that I was curious about is I'm looking at the plan's top 4 chronic conditions: cancer, cardiovascular disease, arthritis, and diabetes. 3 of them, from what I understand, have direct relation to obesity. And I'm sure there's a lot of others if you go down to the top 10 chronic conditions that we're paying for. It seems like we're either treating symptoms of obesity or issues that come from obesity. And let's face it, in Mississippi, we're hunting on a baited field with obesity. Has there ever been a study, or has there anyone looked at treating obesity and whether or not that helps to eliminate some of these other issues that we are the top 4 that we're dealing with: diabetes, cardiovascular disease, and cancer? Is there any studies that would reflect what the treatment of obesity does for some of these other issues? Does it help negate? Is there a savings in the long? I guess that's what I'm trying to figure out. If we, instead of trying to deal with somebody's diabetes or cardiovascular disease, they still, if they're obese, they're going to have other problems that are still out there. So why not try to treat the obesity that hopefully will get them off some of these other medications that they're on, or the issues that they're having as it relates to obesity?
Right. No, and that's a great question. It's something that we have looked at. And so, I can tell you the cost for Ozempic is just short of $1,000 a month.
Yeah.
Indications are that members would have to stay on it for life, that they'll gain the weight back if they don't. When you look at, blood pressure medicine can be as low as $10 a month. Diabetes, we're probably spending, $600 to $800 a month on those. I actually tried to get some cost analysis on that, because we're looking at, probably 65% of our population would be eligible for that medication. At $1,000 a month, it would break the bank. So I actually did have a call with the manufacturer and their representatives, and I said, we listened to, their presentation about the effects on weight loss and treating other chronic conditions. And I said, tell me how much you're willing to sell this drug for. How much does it cost? And they would not tell me. And so they were, the meeting was at their request. They were wanting us to cover the medication. And I said, tell me how much it's going to cost. I was willing to try to negotiate a deal with them for a lower price that we could even think that it would be feasible. And they won't discuss the price with you. They want to charge what they want to charge. And at that point, there's no way I can do a cost benefit analysis if they won't even tell me what they're willing to.
Well, certainly if they
Charge
don't
us for
share a price. So I've talked to a physician that was telling me that they can't get permission to use these drugs in the instance where they have patients that we're not going to operate on them until they lose weight. Well, if they can barely walk, if they can barely move, how are they going to be active enough to theoretically lose weight so they can have surgery, whether it's a disc or something? Has there ever been any consideration of using these obesity drugs to help patients in order, if they have a disc issue in their back, or if they have other issues that they can't have surgery until they lose weight, which would make them mobile again, where they could go back to work, they could be productive? The example I was given was a gentleman that's a truck driver that makes $75,000, $80,000 a year, but has a bad disc issue. and he can't have surgery till he loses 40, 50 pounds. He can't physically walk around at all, but they won't cover an obesity drug to help him lose weight, where he can have surgery, where he can be mobile and go back to work and be productive. Now he's going to be forced to be on disability, and whether you provide for your family. I know these are one-off instances, but do we take into consideration those circumstances when a patient has an issue that where they're limited by their injury or their illness or whatever the case may be to utilize some of these drugs for those reasons? Is that a
We
consideration?
currently don't,
We
because
don't?
it's just a set exclusion that we don't cover any of the medications for weight loss.
Okay. All right. Thank you.
Dr.
I
Blackwell?
would say, I think too, that most of the ones, the study that I've seen, it causes, the result is about a 10% weight loss. So if you're looking at somebody who's 400 pounds and them losing 40 pounds, not sure if that's going to make that much of a difference when it comes to having a surgery.
Thank you, Mr. Chairman. Really don't have a question more than a comment, Senator Harkins. A couple of years ago, when we were doing the tech bill, we looked at bariatric services for Medicaid. A good number of states pay for that procedure. There's a lot that goes beyond that. Obviously, you'd want somebody to try something before the surgery efforts. So anyway, I've been in contact with some folks from the metabolic medicine of Mississippi, and they do pharmacology management of obesity. And so you're going to be hearing more about it. I'll probably bring them in for a hearing and to discuss that, because obesity drives a lot of these other issues that we have: diabetes, cardiovascular disease, which is killing all of us. So I think if we could find some sort of reasonable cure, then on the long term, we'll end up saving money.
We are doing a study now on patients who've had bariatric surgery. We've been tracking them for quite some years. And what we are seeing on our trend right now is that after about 4 years out from bariatric surgery, the majority of the patients have gained all their weight back plus.
Yes, ma'am, you're exactly right. That's what studies that I've seen, and as well as some individuals I know who have had the procedure are back to their original weight. So.
Pro Tem Kirby, you're recognized.
Thank you. Thank you, Mr. Chairman. First off, thank you for all you do. You guys do a good job. I guess this is a comment too, just to inform the legislators. A few years ago, when I was on the Health Insurance Management Board, claims are going out through the roof. And so I asked that we find out who was having all these claims. I thought maybe we could do something about it. And I just knew it was going to be MDOT or someone like that. Well, the study came back and it wasn't even close. It was the legislature. We were by far having more claims than anyone else because of several that had cancer and heart attacks and other things. So I want to let you know that we're the problem more than anyone else. So, but I do appreciate what you're doing. Thank you.
Senator Hill?
I was just going to follow up on, I've not looked at that drug you're talking about that's so expensive that it's $1,000 a month. If it only results in 10% weight loss, I don't understand how it would be $1,000 a month, and apparently everybody's wanting to take it. So I guess maybe I need to look into it more. But I guess my follow-up question would be, does it work? Does it really work? And if you're comparing the cost of that medicine to just the blood pressure medicine and the diabetes medicine, which are not as expensive, if it did work, would you be factoring in the long-term cost, or like maybe one hospitalization for a heart patient or somebody with hypertension or diabetes? One hospitalization is going to top $12,000. Probably one ER visit's going to hit close to $12,000. So that would just be my question, is if you're looking at something other than just the cost of the diabetes medicine and the high blood pressure medicine, if you're looking at like hospitalizations and things like that. And like I said, I don't know if the medicine even works. If it's only 10%, I don't know that it would help us a whole lot. If maybe there's some other ones we could look at, because I do believe, like Josh said, like Senator Harkins said, the root of the problem is better than treating the disease if we could fix the root of the problem and try to, offset some of these other, I mean, you get into kidney failure and everything else with diabetes and stuff. So, I mean, it's expensive as it goes along. So that would be my question, is to look into if there are any drugs that actually do reduce obesity, at a significant amount would be my concern.
So that's been about the rate that we've seen. It's about $1,000, and it's usually about 10 to 12% of weight loss. And so this is kind of how I look at it. Right now, we get for one person about $412 a month. If 60% of our population goes and starts taking $1,000 a month drug, in addition to all the other medications and treatment they're getting, the premiums would absolutely have to go up drastically.
And my second question was, when those doctors you're talking about write those prescriptions and you can't find any history of diabetes in the chart, don't they have to write down a diagnosis to fill that prescription?
There's not diagnosis codes tracked on the pharmacy side.
Okay, so they just present with that and they get it filled.
Yes, ma'am.
So you can't tell what that doctor wrote it for, whether he wrote it for weight loss or diabetes?
We assume that it's treating what it's FDA approved for.
So maybe that's something that we need to look at as to a little bit more detail in writing a prescription or tracking a prescription. If there's that much play in some of those expensive drugs, and maybe just make the pre-authorization on some of those that are expensive and that are being used for other purposes rather than across the board. Because I mean, I've had a lot of people call me and I wanted to know, are you using pre-certification interchangeably with pre-authorization on this, or is that two different things?
So we refer to inpatient admissions as being pre-certified because you're certifying the number of days that they're in the hospital. But we do, because this bill seems to be kind of using them interchangeably, then we did as well.
Because pre-authorization, I guess, would be more for outpatient test or medicine.
It's for everything that we have on that list. With the
Okay, so
exception of inpatient.
you're using it interchangeably, but really you're more concerned with pre-certification on hospital on this thing, because this looks like inpatient stuff.
Yeah, most of it is inpatient.
Okay.
Because we don't have a lot of prior authorizations on medical services. I mean, we've eliminated the majority of those just because we have appropriate back-end edits that we can audit for, and edits, and we make the medical policy available.
So y'all don't do pre-authorizations for MRIs or anything like that? See, that's I'm not under the state health plan, so I'm not part of y'all's problem, but but on the plan that I have with my husband, they just started doing this. And I've had many other insurance providers, people that are under other insurance providers. It's something that they've started recently, because that's when I started getting the calls on not the state health plan, but some of these other ones. But the state health plan on prescriptions is what I've gotten the calls on, is on prescriptions. So maybe we could look at, instead of pre-authorization for some of these things, is it across the board now?
It's
Or is it-
not.
It's just certain ones, certain medicines?
Certain medications.
Okay.
And again, if we can automate that, if if the policy says you need to have tried this drug or that drug before you get that drug, that's automated. The physicians don't have to do anything. When the claim gets submitted, it looks back through their history to see if these other claims are in their history for those other medications. And if it is, it automatically lets the claim go through and it's approved. So like on Ozempic, technically, we don't have a prior authorization on it right now. We have a step edit, which just says you need to try metformin before you can get Ozempic.
So how far back are y'all looking in the patient's records on some of these medications?
180 days.
180 days. So if it's been longer than 6 months and they had the medicine, then they're going to have to go through the pre-authorization. So that's some of the cases that I've had, that they take the medicine like as needed, not every day, but they have another episode of, whatever stomach problem they have, and then they can't get the medicine that they took like 8 months ago. Okay, thank you.
Okay, Senator Harkins.
One more question. You had mentioned something about when you're outside of the state, they pay the same rates as the Blue Cross Blue Shield has in that state. So if you are a Mississippi resident and you go to MD Anderson for cancer treatment, do they cover the treatments that are in that state that Blue Cross covers?
I do.
Okay, so if I wanted to, if I had cancer, I wanted to go to MD Anderson to have proton therapy, which they don't cover here in Mississippi. They'll cover it in,
Well, we do cover proton beam therapy.
they do?
We do.
Okay, all right, well, that's good to know.
We don't cover it for every single service. I mean, we don't cover it.
Prostate cancer,
In some cases, it may be, you
Okay.
know, there was some lesson learned from the last case, and we have revised what the policy is. Blue Cross revised what the policy was for proton beam therapy. Now, any requests for those go out to automatically. Blue Cross is not reviewing those. They're sending them out to the specialist
okay.
for them to review to make sure that that's medically appropriate.
So if they do cover it at that level, then the patient is responsible for everything over that?
They are not.
They're not?
They're not.
Okay,
The patient gets the benefit, as does the plan, for the network allowables in that state.
Okay.
So that was the other big piece of, you know, when we implemented the Blue Card program where we saved 61 million. I mean, it was millions of dollars that the members were not going to be accountable for anymore as well.
what year was that in?
2014.
14, okay. All right, thank you.
I have one more. Is that available on the website? What criteria you're using now for determining proton therapy eligibility? Is there somewhere that we can find the criteria for that?
I know at the time that it was removed because it's so individualized. And so I don't think there is a medical policy online for it right now because we are just sending those out to a specialist in that field for that specialist to look at the studies and make a decision based on the studies for that particular type of cancer.
Because I know when I looked at it before, it was out of date, basically. And we kind of need to know where we are and what that's covering. We could see some of it before. So I think we need some type of update on those procedures so that we can actually see what's being covered and what's not, because that's been a huge issue with some of us in here. And so I would like to see it on paper and see what, medical, whether it's one of those medical medical societies that actually, recommends what's treated and how they do their updates. So whatever you could get to us, in writing on that would help.
Hey, we spent a lot of time last month on pharmacy benefit managers, and we've got time for a couple more questions. The state of Mississippi considers it wise that we hire pharmacy benefit management companies. So we have one representing us. So you've got an expert here right now on how the PBMs are working for the state of Mississippi. Do anyone have any questions on that subject? Senator Boyd?
Ms. Bradshaw, I had a constituent of mine who actually is very much an expert in the pharmaceutical industry and has looked at a number of these contracts for different states and different entities. And the question that he contacted me with, and I think has maybe talked to some other members of the legislature, is that it became very apparent and very clear to many of us that there's lots of conflicts of interest in these clauses. And so he said that we needed to make sure that all relationships are disclosed in the contracts, not just what they feel is a conflict of interest, but that all relationships are disclosed before the contracts are done so that we could evaluate whether or not we perceive it's a conflict or not. Can you tell me whether or not in this, and I'm not asking specifics because I know that's proprietary information, but can you tell us if we are requiring all of those relationships to be disclosed by the pharmaceutical management companies?
So we have not, but since the presentation from Mrs. Khan last time we did, get a copy of the model that she's using to evaluate whether we need to include that in our RFPs going forward. The assumption is that there's not. You know, I know that we've evaluated a program, CVS presented to us recently, and there was some conflict in that. And to just be, I mean, honest, we wanted CVS to tell us exactly how much money they were going to make off of this arrangement with another company, and they refused to tell us, so we've not moved forward with the program.
Okay. And I think the constituent, that the expert was saying that in places where he's seen it maybe, be more effective for companies that they're looking at, for them to disclose all relationships that they have, not just the ones where they feel there's an apparent conflict, because they said that when you do an independent evaluation of that the conflicts seem to come up more when you're given that opportunity. And so I would just ask that we look and make sure that all relationships are disclosed, not just ones that the companies feel there might be a conflict.
So we do ask in the RFP, we provide a list of all the vendors that we're currently doing business with. And we do ask them to provide a statement of compliance as to any of those vendors that they have any business relationships with.
Okay, Senator Hill.
You had mentioned a quoted number for what the plan had spent on breast MRIs. And my question, do you know offhand what the contracted reimbursement is to the entity for a breast MRI? I'm just curious because I got a whole range of prices for MRIs when I was searching around.
Do not have that with me.
Well, that's
But I
okay.
can tell you, I mean, we looked at that last night and it was, I think it was right around the $460 range or something.
460. Okay.
And it varies whether it's done at a facility or whether it's done at a doctor's office or a freestanding.
Okay. All right. Well, that sounds fair. Thank you.
Ms. Bradshaw, thank you so much for your time today. It's obvious how smart you are on the issues, and we appreciate your oversight of our state health plan. Thank you so much. I'd like to thank Committee Assistant Janet for pulling this committee meeting together so nicely, and for Sam, our legal counsel. And I'd like to turn it over to Chairman Zuber to close.
Well, thank you, Mr. Chairman. I just want to say, I want to thank you personally on behalf of the House Insurance Committee. I want to thank you for being proactive and giving the House and the Senate Insurance Committees advance opportunity to gather and get all of the necessary information and expert testimony that we need to have before the session begins. So thank you.
Meeting's adjourned.